Hello, all. Today we will very briefly discuss the treatment issues that often come to us while we treat uh, children with neurocysticercosis. So, few of the tips that you need to remember is that only those with active neurocysticercosis only needs to be treated. Those which are calcified or partly calcified neurocysticercosis needs no treatment. So, anti-helminthic treatments are usually not required. Now, if you are treating an active neurocysticercosis, how do we treat it? If it is a single neurocysticercosis, we usually give albendazole in the dose of 15 mg per kg per day in two divided doses for a total duration of 10 to 14 days. So preferably we tend to give it for 14 days. But if there are more than one neurocysticercosis lesion, especially if it is between 2 to 5 number of lesions, then we can often consider a combination of albendazole with praziquantel for a total duration of 14 days. But if the number of lesions are more than 5, we often consider it to be a multiple neurocysticercosis, and we generally tend to avoid anti-helminthic treatment as much as it is possible. As you all know, steroids are very, very important, and you often give it few days before to few days after you have started albendazole therapy. So usually dexamethasone or prednisolone, we usually tend to prefer dexamethasone in the dose of 0.15 milligram per kilogram per dose in 6 hourly doses. You tend to start the steroids, and on day 3 you start albendazole, and on day 5 you can consider stopping steroids, that is dexamethasone can be stopped. But you need to remember that whenever many of the times what happens is that there will be features of raised ICP that the child can develop once the child is started on anti-helminthic treatment, because the cysticercosis is going to die. It is going to result in an inflammatory reaction, as a result of which a raised ICP feature can develop. So steroids might have to be continued beyond 5 days in such situation, and you might have to give it for a total of 7 days. Now, many questions keep coming to our mind that if it is a calcified neurocysticercosis and there is an edema, should you give albendazole therapy? Everybody says that there is edema, that means there is an active. Please remember that the activity of a lesion is for the lesion, it is not for the surrounding edema. So surrounding edema can be present even in calcified neurocysticercosis, but you need not give any albendazole therapy in such children. But if you detect incidentally one active neurocysticercosis, the question comes that should we treat it, should we not treat it? The answer is very simple. Yes, you need to treat it. But if you have just incidentally detected, but there is no history of seizure, many of the time people say that to treat the neurocysticercosis, but there is no need to give prophylactic anti-seizure medications. Now, if you're getting incidental calcified NCC, so the doubt obviously does not come if it is an incidental active NCC, which is not a very common entity. But incidental calcified NCC is very, very common. Maybe you and me also have incidental calcified NCC. So you need not do anything. You need not worry. You just have to wait and watch in such children. Now, another important thing is stage of the NCC is not very, very clear whether it is, calcified, partly calcified, is it nodular? You're not very, very sure. In such a case, you often tend to treat it provided it is not a calcified lesion. Wherever you have a doubt whether it is to be given or not given, give a benefit of doubt and give it. Now, the most common doubt that keeps coming to our mind is that is it NCC, is it tuberculoma? This needs to get clarified from the radiologist. So this is very, very important that you cannot treat a tuberculoma like a neurocysticercosis. So do not treat it empirically. I have seen few of the physicians often giving combination of ATT and albendazole. So please do not give that kind of combinations. General rule, although there are a lot of data on ways to differentiate tuberculoma and NCC, one of the way in which we should remember is that when you look at the T2 lesion, T2 imaging sequence in which the CSF looks white, the edema looks white, if the underlying lesion is dark, that means it is hypo-intense. It is more likely to be some caseous material. If the inside lesion which is there is bright, that means within that lesion there is probably fluid. That means there is a cyst. So this is probably a neurocysticercosis. So remember that T2 core being hyper intense is likely to favor neurocysticercosis, especially active neurocysticercosis, whereas if the T2 is hypo-intense, then the core of the lesion, it is more likely to be tuberculoma. This is a very common thing which radiologist often tends to do to differentiate both of them. So that means when you are encountering a child with viable neurocysticercosis, all that you need to do is that it is to ensure that you are not treating multiple NCC. Number two, you're not treating intraventricular neurocysticercosis with albendazole because it's going to rupture, it's going to result in obstructive hydrocephalus. So intraventricular NCC is a strict no. Similarly, subarachnoid, for the same reason, subarachnoid neurocysticercosis also we generally do not treat it with albendazole, and known ocular neurocysticercosis and spinal neurocysticercosis. These are five clear-cut contraindications for giving albendazole therapy. If you have excluded all of these things, then how do you exclude intraocular? Unless and until you do indirect ophthalmoscopy, it is not possible to exclude. So you should do indirect ophthalmoscopy to rule out intraocular cysticercosis. And once that is ruled out, then you start the child on oral dexamethasone, as I told you, 0.15 mg per kg per dose for a total of 5 days. It has to be given 6 hourly from day 1 to day 5, or you can also give 1 to 2 milligram of oral prednisolone, and oral albendazole, as I told you, 15 mg per kg per day in two divided doses for 7 to 28 days, but preferably we tend to use it for 14 days as per the recent recommendations. Now the next question comes that, okay, I have treated the child with anti-helminthic treatment. Should I now get a CT? Should I get an MRI at the follow-up? The answer is very, very clear. As far as children are concerned, we always prefer MRI over the CT scan for the fear of the radiation exposure. Now the next question comes is that when should I do this MRI? There is no clear-cut guideline, but we generally tend to follow the practice of 6 months to 8 months. It is at the an interval of 6 to 8 months that you tend to do an MRI. Now, when you get a repeat MRI, you look at the status of the cyst. If the status of the cyst is still active, then you will have to repeat a course of albendazole. Rather, you should now prefer a course of albendazole with praziquantel. But if the repeat cyst status of the cyst is calcified, then there is no need to repeat the entire course. Now, the next question comes is that how long should I give anti-seizure medication? Generally, the rule is that we usually give it for a duration of 2 years. If there is a complete cyst resolution earlier itself, that means you got an MRI done after 6 months and you saw that cyst has completely disappeared. You got an EEG done. EEG is also totally normal. You can consider tapering anti-seizure medication a little earlier also. But usually they are often required for a duration of 2 years. But remember to get an EEG before you start tapering the